In this particular section, we'll be discussing on one of the very common topics on hypothyroidism. Hypothyroidism, we can split into two sessions basically. The first session is all about understanding the investigatory part. Even though we have discussed some of the basics of the workup and the diagnosis in the previous videos itself, understanding hypothyroidism itself needs a lot of understanding about the TFT. So that is why I want to discuss a lot of TFTs. At the same time, I'm going to give a little bit of importance about the congenital hypothyroidism also, which is often a very neglected topic in the upcoming sessions. So with this, we'll start with the hypothyroidism section, and to start with, I'll start with the TSH. So we're going to start with the thyroid stimulating hormone first. But even before going into thyroid stimulating hormone, let us recap some of the basics. So we know we have a controller, that is the hypothalamus. This hypothalamus is going to control your pituitary through a hormone called as TRH. This is a thyrotropin releasing hormone, or otherwise referred to as a TSH releasing hormone. You can call it in any way, right? So this hormone is going to stimulate the thyrotropes. You know, if you recap, you'll understand this is the smallest hormone ever known. I mean, peptide-based hormone, only 3 amino acids, glutamate, histidine, and proline, right? And it's going to stimulate the thyrotropes. And at the same time, it can, to an extent, stimulate the lactotropes to secrete prolactin as well. But the most important will be on the thyrotropes, which is going to release TSH. So this TSH will obviously act on the thyroid gland through TSH receptor that is present on all the thyroid follicular epithelial cell. So this TSH, you know, it's going to stimulate the gland because TSH is having a trophic action, in the sense they can increase the size of the gland, they can increase the vascularity of the gland. At the same time, it increases the iodine uptake by stimulating the sodium iodide transporter molecule also. Remember, the TSH is the best stimulator of thyroid to take up the iodine. I don't think there is any other better stimulator than TSH to stimulate the thyroid gland to take up iodine. So it's going to take up iodine, it's going to increase vascularity, it's going to increase the size of the gland. Ultimately, they are going to increase the production of thyroxine, that is T4, and triiodothyronine, that is T3, even though we know that the majority of the output from the thyroid gland is made of thyroxine, that is T4, right? Now you have a lot of peripheral organs like liver, kidney, so where they try to process this thyroxine T4 using a D1 deiodinase. We know this already, we have studied the basics in the workup and diagnosis section and the physiology section itself. So D1 deiodinase is going to convert this T4 to T3. So which means T3, the primary source, even though it comes a little from the thyroid, the primary source of T3 that is circulating is the peripheral conversion by the D1 deiodinase from T4 to T3. So this T4 together with T3, obviously they are going to give feedback to the pituitary and the hypothalamus. These are negative feedback regulation, right? T3 along with the T4. It's not like only T4 or only T3. Both are going to give feedback to the hypothalamus and the pituitary. Right. So this is the feedback loop. That's what has happened. So, you know, like in hypothyroidism, whenever you have a problem in the thyroid gland, we call it as a primary hypothyroidism. Whenever you have a problem in the pituitary, we're going to call it as secondary hypothyroidism. Whenever you have a problem in the hypothalamus in secreting TRH, we call it as a tertiary hypothyroidism. But to be honest, you know, like as a clinician, I don't want these many types. So secondary and tertiary type of hypothyroidism, I'll be just calling it as a central hypothyroidism. As simple as that. So I'm just going to finish off by telling central, but truly, you know, like secondary and tertiary behave like almost the same. So there's no much big difference in them. And apart from that, you have thyroid hormone resistance in the periphery, congenital hypothyroidism, many other different types are there, but we'll discuss in the subsequent sections. But right now, let us go and discuss about one more physiological part. We can recap that, the difference between the T4 and the T3. We know that T4 is less potent, which means in the sense it's less biologically active, less active compared to that of the T3. T3 is very highly potent. By definition, it is almost 3 to 4 times more potent than T4. Clear? And it is more active in the sense it is the hormone that is going to be biologically active. But in the exam, if they ask you which is the hormone that is biologically active, you have to answer it is T3 only, because T3 is the one that is the hormone inside the cell, which means whatever T4 that influxes into the cell will be converted to T3 once again by the D2 dehydrogenase that is present inside the cell, which means this T3 is the biologically active hormone. But what will be the plasma levels? Plasma levels, on the other hand, is more with T4 only. Plasma levels are actually lesser with T3. There are a lot of reasons for that. First reason is the T half, and the most important reason is the T half of the thyroxine. T half of the thyroxine is approximately 1 week, whereas the T half of the triiodothyronine is only 1 day, 7 day versus 1 day. Which means the half-life is more for thyroxine, and probably that is one reason why it is circulating at very high levels. At the same time, it is more stable. You can see from the half-life itself, it's 1 week. So it's relatively more stable in circulation compared to that of the T3, right? And the plasma levels, if you ask me how much is more compared to that of T3, T4 is actually 15 to 20 times more in comparison with T3. Okay. So how much they are protein bound? Protein bound in the sense like almost 99.97% of the T4 is protein bound, and 99.7% of T3 is protein bound. That gives us the free form as well. The remaining must be the free form. So the 0.03%, some books tell 0.02, 0.03 or 0.02% of T4 is unbound form, which means majority of them are circulating in the bound forms only. Clear? Whereas T3, 0.3% is in the free form, and remaining everything is in the bound form only. Fine. That also tells you one important concept, that what are the binding proteins, that also we have to know. So which means so much of them are protein bound in the sense. So what is the protein that is binding them? We already saw in the physiology section that are 3 proteins that bind them. One is the TBG. This is the most important, and maximum binding will happen with this TBG only, because this is the one that has the maximum affinity for thyroid hormones. Maximum affinity for thyroid hormones. And second one, we have a type of protein called TTR, that's called a transthyretin, and third one we have albumin also. Albumin is the one that has the least affinity, but the capacity wise albumin is the maximum. TTR, we know it's the protein that carries thyroid hormones in the cerebrospinal fluid and into the brain. So all these points are really important. But remember, the maximum carrier under physiological conditions is the TBG. Remember, TBG is the one that predicts the amount of total hormones and the bound hormones. The more the TBG is, more will be the bound hormones and the total hormones. Lesser the TBG is, lesser will be the bound hormones and the total hormone level. So we'll discuss about that in the T3, T4 section. So not now. But at the same time, you also have to understand, I told you albumin in general has lower affinity for T4. This is normal. Lower affinity for T4 and T3. There are certain conditions which I will be discussing for sure in the later half of the session, where albumin will have increased affinity, abnormal increased affinity for T4, but not for T3. Increased affinity for T4, almost similar to that of TBG, but not for T3. So this is an abnormal increased affinity due to mutation in the albumin. So this is seen in certain families in the near the Mediterranean region, and this is called as familial dysalbuminemic hyperthyroxinanemia. We'll be discussing about that, so don't need to worry much about that. That's called a familial dysalbuminemic hyperthyroxinanemia. So this is the disease, so that we need to understand as well. So what is the source of this T4 and T3? We know the source of T4 is solely from the thyroid gland. Thyroid is the only source of T4. What is the source of T3? On the other hand, T3, the source are 2. One is it's coming from thyroid gland, even though in low amounts. 80% of the thyroid gland secretion is T4 only 20% is T3. You know that thyroid gland does secrete a little bit of T3, but the most important source of T3 is not thyroid gland. It is peripheral conversion. Very, very important point. It is peripheral conversion. This is the major source of circulating T3 in the blood. Clear? So these are some of the differences between T4 and T3. We have to know this, then only we can move on to the actual topic, that is the TSH. So my question is, why TSH? Why we are using TSH in the first place? But before that, we need to answer the question, what are the types of hypothyroidism we have? So you have many different types of hypothyroidism. Based on T3, T4 and TSH levels, you can determine. So whether it is free or total, we have not yet discussed. We are talking about TSH now. So for to understand this, we need to know this. So we have something called a primary hypothyroidism. So in the primary forms of hypothyroidism, we have overt forms and we have subclinical forms. We call it as subclinical hypothyroidism. I write as SCH. So in overt, you know, T3, T4 will be low, TSH will be high. Obviously, there is no doubt about that. Similarly, in a subclinical hypothyroidism, we know that T3 and T4 will be normal, so the TSH will be high. So my question will be, why in a subclinical hypothyroidism, T3 and T4 is normal, and how can you diagnose this as, first of all, a thyroid-related disorder? How can you put this subclinical hypothyroidism picture under a primary hypothyroidism? That's what my question is. I told you the logic in the thyroid diagnostics lecture itself, where I told you this high TSH is needed to keep the gland from secreting the thyroid hormones, which means you need that high TSH to keep the gland going forward. Otherwise, the gland will not secrete sufficient hormones. If you want a continuous stimulus to maintain a normal secretion from the gland, definitely that is a problem in the thyroid gland only. So that's why it's put under primary hypothyroidism, point number 1. Second, you can imagine a reverse way. So if the T3 and T4 are normal, why the TSH is raised? You might ask this question. So why this is happening? So that's what you're going to answer in some time. So what about secondary and tertiary hypothyroidism, or we can write it as a central hypothyroidism? Central hypothyroidism, you have a variety of changes in the TSH. But in your physiology textbooks, they would have given low T3, low T4 and low TSH. They would have finished simply, but please trust me, it is not only low TSH, it can be normal, which is actually very common, or even it can be mildly increased also. So it's very, very difficult to find out a central hypothyroidism. I'll tell you how to find out. So, but before that, let us see why in subclinical hypothyroidism in the first place, you have these kind of changes and why TSH is the single best standard test for diagnosing a primary hypothyroidism. So hereafter, it's everything about TSH for some time. Very, very important. So this graph will tell you why TSH is the single best investigation for diagnosing a primary hypothyroidism, as well as why TSH is a single best investigation for monitoring treatment for primary hypothyroidism. Clear? So this graph shows the plotting between the T4 levels and the TSH. What you are seeing is a curve like this. Clear? So what this curve shows is the fact that T4 and TSH have something called a log linear relationship. T4 and TSH has a log linear relationship. So what do you mean by log linear relationship? This is logarithmic relationship. So which means even a small change in one compound may induce a drastic change in the other compound. So this is what we refer to as a log linear relationship. So in this condition, even a small change, you can see here, even a small change in the T4 induces a drastic change in the TSH values. That is the idea. So how can it be understood in a subclinical hypothyroidism patient? It's quite simple. In a subclinical hypothyroidism, let us assume you have this T4 range. This is a thyroxine range, which is point A and point B, which is considered to be the reference range, or otherwise indirectly I can tell it as a normal range. But we tell only a range to simulate the entire community, but we don't know what is normal for that particular patient. That particular patient has some fixed level that their body senses has to be normal. So let us assume their T4 level is fixed at this particular cutoff. So once the T4 reduces, and still it is within the normal, but it reduces in the sense it's going to come to a lower level compared to that of what they usually tend to have. And this little change in T4 from a higher level to a lower level, but within the reference range, for us it is a normal T4, but this will induce a massive increase in the TSH, which means even though the T4 is a little low normal, still it's maintained within the reference range, but the TSH is grossly increased and goes outside the reference range and becomes abnormal. So that is the concept of this subclinical hypothyroidism. How can you pick up with the TSH, thyroid stimulating hormone itself? That is why this understanding about this log linear relationship is really, really important. So what are the generations of TSH assays? TSH assays have a lot of generations. We actually started with the first generation. This is the first generation assays, which is mentioned here, which had a sensitivity of approximately 1. And we have improved to second, third, and fourth generation assays with subsequent tenfold improvement with each passing generation. So let us write here, what are the generations? We know we have a first generation, and what is the sensitivity of detection? It is only 1 milli international units per liter. But what is the assay used? Assay actually used a traditional simple RAA. This is what the assay used. And we had second generation. Second generation sensitivity became tenfold better, that is it became 0.1. And moving from first generation, second generation was really important, because it's not important for hypothyroid patients, but it's very important for hyperthyroid patients. Because in hyperthyroid state, you know the TSH is going to reduce, and you know the normal TSH. Let me write the normal TSH here. Normal TSH is quite controversial, but according to AAC, American Association of Clinical Endocrinologists, 2011, it is somewhere around 0.5 to 4.12. So this is the normal TSH if you don't have the lab reference. But what ATA, American Thyroid Association, 2017 guidelines have mentioned is the fact whatever your lab gives, you can follow that. For instance, the upper limit of normal is what is more important. So which you can take it as 4.5 or 5 depending on what your lab tells. So you can take it as 5 also, no problem. If your lab says 5, take it 5 as the upper limit of normal. No need to keep a stringent cutoff of 4.12 or not. Clear? So this is the ATA 2017 guidelines, which means I generally keep upper limit as 5. After 5, I will think a little bit TSH is elevated only, or at least I'll think as a high normal TSH. I will not take it as a purely normal TSH unless until it is less than 5. So in hyperthyroidism, you know the TSH is going to go below the cutoff, lower limit of normal, that is 0.4 or 0.5. So if it goes below the 0.4 or 0.5, the first generation will not be able to detect that. The first generation will not be able to tell whether the TSH is in the normal range, that is if it's 0.8, I will take it as normal. 0.6 also, I will take it as normal. But if the patient is hyperthyroid, it will be less than 0.5 or 0.4, in fact less than 0.1 sometimes. So that and all cannot be detected with the first generation TSH assays. That's why we had a second generation which used immunometric techniques, but they used isotopic method, which means they used this iodine 125 isotope. So this is the second generation. It led to good improvement, and even now, you know, like your lab, if you don't ask for high sensitive TSH assays, they will follow the second generation assays only, where they are going to tell the range between 0.6 to 5 or 5.5. So you know that it will be within the range. It will be within the sensitivity cutoff of second generation assays only. And next came the third generation assays, which use the same immunometric techniques, but it involved non-isotopic techniques. It didn't use I-125 non-isotopic and chemiluminescent or chemiluminometric assays. So this is what they preferred. And this led to a much better sensitivity of 0.01, which means you can another 10-fold improvement, 100-fold improvement for the first generation, 0.01. This is the sensitivity of third generation. Now we have the newer fourth generation assays also, which is using modern immunometric techniques, which has a much improved sensitivity of just 0.001, which is very helpful in certain conditions like severe hyperthyroidism and thyroid storm. So that's the only area where this much sensitivity is very useful. Apart from that, it's not that useful. But third generation, when will you need? when will you need a third generation? That's, I mean, second, third and fourth generation, we call it as sensitive TSH assays. And this fourth generation is also referred to as high sensitive TSH assay, highly sensitive TSH assay. And the second generation is low sensitive TSH assay. First generation is insensitive. They are not used anymore, first generation. Either second, or if you want sensitive assays, they can go for third and fourth generation. Fourth is the highly sensitive. Highest sensitivity is the fourth one only. So when you might be needing a third generation or fourth generation in certain conditions. For example, in a thyroid storm. In a thyroid storm, usually TSH will be undetectable. It will be even below the 0.001 cutoff. So that's why that makes you a good diagnosis. I'll tell you when I'm going to discuss about the thyroid storm in the subsequent section. So it will be undetectable. So that might be useful there. And third generation may be used for non-thyroidal illness. In non-thyroidal illness, you might have a low TSH, which is below the 0.1 cutoff. So it might be 0.08 or 0.07. So in these conditions, to detect them, you need a more sensitive TSH. So that's why we have this third and fourth generation. Otherwise, second generation must be mostly enough. And modern techniques, the third and fourth generation generally prefer using a sandwich technique, where they use biotinylated anti-TSH antibodies, which I'll tell you in some time what is the importance of that assay. You can see this diagram explains a lot of things. The first generation, first let us finish it off. The sensitivity is 1. Second generation, the sensitivity is 0.1. And the third generation, you can see the sensitivity is 0.01. And finally, the fourth generation assay, the sensitivity is 0.001. So these are the sensitivities. And the third and fourth generation assays are especially useful in a hyperthyroid patient. Whenever the TSH is in the hyperthyroid range, very, very low TSH, that can be picked up only by third and fourth generation assays. The first and second generation assays cannot pick up. Remember, the first generation assays can't even pick up normal range itself. Clear? So the normal range itself is little bit away from the first generation assays sensitivity. So that's why I told you 1 units, like the first generation assay can't even pick up the normal range sometimes. So that's why it is not used anymore. So these are some of the things that you have to know as an initial part of knowing TSH. And now we have to see the pitfalls. What are the pitfalls of TSH? The most important pitfall is TSH is highly variable. Between populations, between ages, between sex, between children, that too in the newborn versus a older child, and it varies in pregnancy. So many changing factors are there for your TSH. So that's why it's very important to understand. The first one is the common demographic pattern. So where there are 4 things that influence the TSH. First is the age, second is the sex or the gender, third one is the BMI, and fourth one is the race. So these are the 4 things that predict changes in the TSH. In this, the 4th thing we don't want, because Africans generally tend to have a low TSH, but that is a race-related changes in the TSH. But as far as Indians are concerned, in our population, this is right now not that much needed. Then what about the age, gender, and the BMI? Age, as such, is a very important predictor. Increasing age will have increasing TSH, irrespective of the gender. Similarly, gender itself is a very important thing, because females itself tend to have a higher TSH, irrespective of the age and irrespective of the population you are dealing with. So these are independent things that increase the TSH. Age, similarly, increased age will have increased TSH as well. BMI, when it is increased, again it can increase TSH, which means obesity itself can increase the TSH to an extent. Majority of the very obese patients are usually diagnosed as hypothyroidism whenever they have a small increase in TSH, and that's really wrong. Because in obesity, there is something that happens that called an altered thyroid. The entire HPA axis itself will change a little bit so that the TSH will be a little excess. So you have to understand the obesity is the reason for that mild increase in TSH and not the increased TSH causing obesity. And unnecessarily, these people will be put under treatment with levothyroxine. So no need to unnecessarily do that. So obesity itself can alter the TSH. You have to know that point. Then this graph will show you in any age group, you can note the fact that females always have a higher TSH. Irrespective of what age group they belong to, females always tend to have a higher TSH. At the same time, you can see irrespective of whether it's a male or a female, age itself is a very big influencing factor, so that with increasing age, you get increasing TSH. And there are a lot of theories revolving around this increasing TSH with increasing age, but even certain theories are telling this increasing TSH in old age is actually protective. So many controversies are there, whether to treat or whether to not treat. So let us discuss in the treatment section, not now. Now let us see the second pitfall that happens during pregnancy. So we know the TSH levels will be variable during pregnancy, but when it will be variable? Let us draw. You can see this is the TSH which I am showing in the graph. You can see the TSH, it's the rock bottom, which means TSH levels are decreasing in the first trimester, especially in the late first trimester of the pregnancy. And what is the reason for that? Because there is one other hormone that is actually increasing during the first trimester of pregnancy. Later on, it comes back to normal. This hormone that reaches the peak during the first trimester, especially the late first trimester of pregnancy, is the beta-HCG. Because beta-HCG is increasing, your TSH is actually dropping. You might be asking what is the relationship between this beta-HCG and TSH. We have already known this fact that beta-HCG and TSH are relatively similar with regards to the alpha subunit, which means whenever beta-HCG levels are rising, to an extent it is similar to the TSH is rising. So which means this increasing beta-HCG will produce increased T3 and T4. This is often referred to as a gestational hyperthyroidism. Very common, no need to do anything. Just leave it alone. And after the first trimester, it will resolve. And this increased T3 and T4, obviously by feedback, this will reduce the TSH, right? So that's why in the first trimester, the beta-HCG is high, your TSH levels are actually low. You can see and correlate with the thyroid hormones as well, where you can see the thyroid hormones are actually increasing in the late first trimester, corresponding with the peak of the beta-HCG, right? And after some time, you can see in the second and the third trimester, the thyroid hormone levels are actually reducing. You may be asking why they are reducing compared to the pre-pregnancy level. The reason why the free hormones are reducing is the fact that there will be another important event that is happening in the pregnant mother, that is the placental deiodinase levels will be increasing, because as the placenta picks up its growth in the second and the third trimester, they secrete a lot of D3 deiodinase. You know what D3 deiodinase does? It produces a lot of reverse T3, which is an inactive compound, which means the T3 levels will drop and the reverse T3 levels will increase. So that is the reason why this free hormone levels are decreasing in the, you can see that it's decreasing in the second and the third trimester over time. But one other thing is increasing here throughout the pregnancy. It reaches a plateau and maintains the same, that is the thyroid binding globulin, TBG, which means the capacity to bind thyroid hormones and the total thyroid hormones will actually increase in a patient who is pregnant throughout the pregnancy till delivery. And one corresponding thing that comes along with the TBG is the total T4, the total hormone level. The total hormone level includes bound and free. Here the bound hormone levels will go in excess. So that is the reason why the total hormone level tends to increase. So there will be a lot of equilibrium that is happening. Albumin changes will be there because albumin levels will drop actually because of the hemodilution. Albumin will little bit decrease in pregnancy. We know that's one of the important physiological change that happens in pregnancy. So since there are a lot of dynamics happening in pregnancy, you have to think that the total T4 as well as free T4 both are unreliable during pregnancy. But it has been considered traditionally that the free T4 is more unreliable during pregnancy compared to the total T4. That's why many societies recommend total T4. But this and all is not applicable right now. But anyway, you can remember that total T4 is a little bit more reliable compared to that of the free T4 in pregnancy, because free T4 goes for a lot of dynamic changes in the pregnancy. Deiodinase activity, then your TSH, like decreasing and then increasing. So much things will alter the free level. So total T4 is at least relatively to an extent is predictable in pregnancy because of the expansion of the TBG, so that you can correct that total T4 for the TBG expansion, which I'll be discussing in the upcoming minutes. So don't need to worry about that. So this is the reason. At the same time, one more thing you can observe is the fact that the fetal thyroxine starts by around 12 weeks of gestation. The importance of the fetal thyroxine and the maternal thyroxine and the impact of thyroxine on mental health of the fetus and the child is depicted way back in 1888 in the Clinical Society of London. But we know, which means why I told that point is we know that almost more than 100 years and 150 years, we know that thyroxine is important for the mental growth of the fetus. So it starts, the thyroxine and the fetus, it starts by around 12 weeks. Till that time, the fetus is completely dependent on the maternal thyroxine. Completely dependent on the maternal thyroxine. 100% dependent on the maternal thyroxine. So which means this is a very crucial period. The first 12 weeks, this is an organogenesis period, very crucial for the growth of the brain. So if there is some problem here, especially iodine deficiency, they will end up with the cretinism. That is the problem in this period. But subclinical or other types of hypothyroidism will result in little bit lesser IQ or a probable autism. That is not proven yet, but little subnormal IQ may be there, but not a pure cretin. Cretin is always a defect in oral intake of iodine. So which means it's an iodine deficiency disorder. Don't equate that cretinism with the maternal hypothyroidism. Cretinism is more of an iodine deficiency disorder than you put under maternal hypothyroidism. You might be asking, what is the difference between maternal hypothyroidism and iodine deficiency? There is a difference. That's why I'm telling you that point. Maternal hypothyroidism is a little different, or a pure hypothyroidism itself is a little different from iodine deficiency disorder. You might be thinking that iodine deficiency disorder causes always hypothyroidism only. No, we'll discuss in due time. Clear? So these are the important points I wanted to tell. So that is the reason why in the first trimester, the TSH is actually low. That made the guidelines to change the cutoff for the TSH in the first trimester of pregnancy. So what are the cutoff? So initially we had 2 to 3 different guidelines. We tried to follow the AACE guidelines in 2011, which said that in the first trimester, the upper limit of normal of TSH should be 2.5. In the second and the third trimester, your upper limit of normal for TSH should be 3, or probably 3.5 in the third trimester. So this is what the AACE guidelines told in 2011, but this is completely removed currently. We don't follow right now. The ATA 2017 guidelines, there's a guideline update. 2017 guidelines clearly told that this much lower cutoffs are generally unnecessary. In the first trimester, you just keep a cutoff of 4. It is lesser than the non-pregnant cutoff, but still you keep a cutoff of 4 in the first trimester. That is to adjust to the lower TSH that is normally seen in the first trimester. And in the second and the third trimester, you can keep a little bit more liberal cutoff, like you can just make the cutoff as non-pregnant individual. So what is the normal TSH for a non-pregnant individual? The upper limit of normal will be applicable here also, similar to that of non-pregnant people. So this is what ATA, American Thyroid Association, 2017 guidelines have mentioned. This is a correction that they have done, very important one. Currently, the first trimester, upper limit of normal TSH cutoff is 4. Be very clear about that. Fine. So these are some of the important impacts of knowing these graphs. So let us now move on to see the third pitfall of TSH, which means it is very, very unreliable in the diagnosis as well as monitoring treatment in a patient who is having a central hypothyroidism. Very, very unreliable. Why it is unreliable? Let us see. This patient is off levothyroxine. LT4 means levothyroxine. Off levothyroxine in the sense this is at the time of diagnosis when the treatment has not been started. So what are the TSH values in a patient with a central hypothyroidism? We can clearly observe the fact that it is low in 19%, it is normal in 70%, it's even a little bit mildly elevated in almost 11% of the cases, which means it's not very reliable at all. So normal is the most common form. 70% of the patients with central hypothyroidism had a normal TSH. Usually they will have a low normal TSH, but still they had a normal range according to our cutoffs, reference intervals. But what happened when you started the treatment? When you started the treatment, something drastic happened. The TSH dramatically dropped. A lot of patients went to undetectable TSH. They become low in almost 80%. So why these observations are very important? The first reason is, you can go back to our initial discussion and you can see I have clearly written, in central hypothyroidism, the TSH may be decreased, normal, or even mildly increased. So obviously, you know, the normal is the most common form. That is the reason why TSH is highly unreliable in the diagnosis of central hypothyroidism. You need a different diagnostic technique, which I'll be discussing in some time. But how will you monitor a primary hypothyroidism? Obviously, in a primary hypothyroidism, overt or subclinical, if at all you are starting a treatment, what are you planning to do? You give some levothyroxine, all right. And what is the target? Target is here TSH is increased initially. So to bring the TSH back to normal, which means you are trying to reduce the TSH and bring it back to normal. So that is the idea. Suppose, let me say that the TSH is low. After giving levothyroxine, the TSH become very low. The decline in the TSH is too much that it went below the cutoff, what you are trying to do. So in this condition, you know that you are giving a higher dose of levothyroxine. So increased dose is there. So if you observe this pattern, you are trying to reduce the dose of levothyroxine so that once again you can normalize the TSH. The idea is to keep the TSH in the normal range. Dose has to be titrated accordingly. If you give a higher dose, TSH will go below the normal range. Clear? So these are the major concerns here in a patient with a secondary or a central hypothyroidism. So what you're seeing or what you're observing here is the fact that just giving a 50 microgram per day, trust me, this is nothing in an adult. Usual replacement dose is 1.6 microgram per kilogram per day. Even a 60 kilogram man or a woman, it is almost 100 micrograms. So just giving 50 microgram per day is nothing. That itself made the TSH fall below the reference range, which means undetectable TSH. So which means the pituitary suppress the TSH very fast in a central hypothyroidism. Understandable, yes. But there is a danger that the treating physician may think that this fall in the TSH is a sign of over-treatment. Some physicians may falsely think that this fall in the TSH, like what we did in a primary hypothyroidism, he might think that this might be a sign of over-treatment with levothyroxine and he will try to reduce the dose, which is completely unnecessary. Clear? So here the 50 microgram is not at all enough in the first place. And since the pituitary is already under suppressed state, even a small dose of LT4 will suppress the TSH to undetectable range or below the cutoff. So no need to unnecessarily panic about that. No need to lower the dose, thinking that we are giving over treatment to the patient and try to even increase the dose. So that is the reason why do not see the TSH for monitoring in a patient with a secondary hypothyroidism or a tertiary hypothyroidism. So which means TSH monitoring is unreliable. That's all, over. For diagnosis as well as for monitoring secondary hypothyroidism. Clear? So how will you diagnose then a patient with the central hypothyroidism? So that's why we have this. This is called a TRH stimulation test. This is considered to be one of the gold standard for diagnosing secondary and tertiary, that is central hypothyroidism. So what you are doing in a TRH stimulation? You give a TRH, you know that is going to stimulate the thyrotrophs to produce TSH. But how fast they produce the TSH and how much they produce the TSH, both are important. That's what we're going to see here. Let us see. So this shaded area here tells you the normal range. So I can draw an approximate line. So this is the normal for your reference. In the first graph, we are only seeing two diseases, primary hypothyroidism and primary hyperthyroidism, and how they are going to behave. A primary hypothyroidism is going to behave something like this, which means there will be a drastic increase in the TSH in response to, in relationship to the TRH stimulation. Why? Because this low thyroxine in a primary hypothyroidism makes the pituitary already stimulated so much. Already, like a stimulated pituitary, because of the low thyroxine in the blood, if you stimulate it further with TRH, they are going to boom. They are going to blast the TSH out of them and they are going to result in a significant peak, very fast rise and a significant peak compared to the normal individual. So this is a primary hypothyroidism. In a primary hyperthyroidism, on the other hand, it is very, very clear that the TSH is not released at all, which means high thyroxine in a primary hyperthyroidism from the thyroid already has suppressed the pituitary enough. Even if you stimulate the suppressed pituitary by TRH, it doesn't get that much stimulated, so the TSH will not be released that much, so it remains in the baseline only. It's much lesser compared to that of the normal curve. So this is what you are going to get in a primary hyperthyroidism. So what you are getting in a patient with a central hypothyroidism. So we are now discussing about the central hypothyroidism. Usually the secondary hypothyroidism we also called as pituitary hypothyroidism. Tertiary hypothyroidism we also called as a hypothalamic hypothyroidism. You know that. So let me draw the normal curve first. When I draw the average normal curve, this is going to behave something like this. You can see the peak at what time happens and how much it rises and what is the plateau, everything you can see in this particular graph. What happens in a pituitary hypothyroidism? In a pituitary hypothyroidism, obviously the problem is in the pituitary doesn't respond to anything. Which means even though the T4 is low, that itself can't stimulate the pituitary. How come the TRH can stimulate the pituitary? That's why the line is flat. Pituitary is not responding to TRH as well as T4 here. So that's why it's a secondary hypothyroidism or a pituitary level hypothyroidism. TSH is not rising in relation to the TRH stimulation. But what happens in a tertiary hypothyroidism? In tertiary hypothyroidism, you can see the curve follows this kind of pathway, which means that TSH is rising when you are giving TRH. Yes, that should be the case because in tertiary, the TRH deficiency is the problem. So TSH must rise, pituitary is normal here, but it is delayed. So that's very important. You can see the peak is not reached similar to that of the normal patients. They rise the TSH, increased TSH is there, but you are seeing a delayed response or a delayed peak. That's what will tell you this patient is having a hypothalamic hypothyroidism. Clear? So the gold standard to find out a central hypothyroidism or a diagnosis central hypothyroidism is to give TRH stimulation test. So no response after TRH stimulation, likely a pituitary level hypothyroidism. Response is there, but a delayed peak and delayed response if you see, that is suggestive of a tertiary or a hypothalamic hypothyroidism. So these are the important principles that you have to know. Then what is the fourth pitfall? So this is the third pitfall we have seen, fourth pitfall. Fourth pitfall I wanted you to tell on assay artifacts. These are the assay artifacts, which means there are some things that interfere with the assay. The most important thing they'll be asking you that interfere with the assay is the biotin. Biotin is supposed to interfere with the assays of TSH. Whenever you are taking biotin at a dose of more than 5 to 10 milligram per day, which is nowadays quite common because many people are taking multiple multivitamin tablets, so which might increase their biotin in the blood. So this excessive biotin intake, because it interferes with our assays, you might result in a falsely low TSH, either a falsely low TSH or a falsely elevated T4 and T3 probably. So this is quite common whenever you are taking a biotin in such a high dose. Why? Because our current generation TSH assays, the third and fourth generation, typically use this biotin-related anti-TSH antibody. I can draw the biotin here. This is the biotin-related anti-TSH antibody. That's a biotin component there. This is an anti-TSH antibody. And they also give a ruthenium-labeled anti-TSH antibody. Both antibodies, if there are any TSH molecules that are circulating in the serum, they will capture. Like this is called a sandwich capture. So they capture this TSH from both the ends. One is this biotin-related antibody. Second is the ruthenium-labeled anti-TSH antibody. Both will capture this TSH. Once they capture this TSH, this biotin-related anti-TSH antibody will have biotin attached to it. So after this capture has happened, this biotin-related antibody will go and bind with the streptavidin. We know that this streptavidin is having high affinity for biotin. So since there are streptavidin, this biotin portion of this biotin antibody will come and attach with the streptavidin. This is called streptavidin biotin capture. And once this capture happens, then only you will result in chemiluminescence and change in the color or light fluorescence and all these things, and that is the reason why tell how much TSH is there depending on how much luminescence is happening. So for that you need that capture, then only the luminescence will happen. So amount of luminescence will tell amount of capture, and similarly amount of TSH as well. So let us see what happens if you are taking so much of biotin. So this is a patient who's taking a lot of biotin. So here the antibody sandwich will not be a problem. Here the biotin antibody, this is the biotin. Here the biotin antibody and the ruthenium labeled antibody, anti-TSH antibody is capturing the TSH. No problem, the sandwich capture is still there, but it will not be captured by the streptavidin, because this excessive biotin, since this is having high affinity for the streptavidin, they will come and bind with streptavidin, and they will prevent this biotin antibody from binding with the streptavidin. So which means your binding and this biotin antibody streptavidin capture will not happen, and all these streptavidin sites will be occupied by biotin only that you are taking in excess, and resulting in a undetectable TSH, which means the TSH cannot be detected in this case, resulting in a falsely decreased TSH. Clear? So this is the reason. But anyway, the mechanisms are not important, but this point is really important, that taking excessive biotin may result in falsely lower TSH. Clear? This is an assay artifact. This is pitfall number 4. Pitfall number 5, newborn. So it's not a pitfall really, but you have to understand the physiology better. In newborn, physiologically itself TSH will be high. So which means it poses a diagnostic challenge. In a newborn, it poses a very good diagnostic challenge to diagnose congenital hypothyroidism cases. Congenital hypothyroidism is quite common. It's not like very common. It falls between the common and uncommon range. It's not like very uncommon also. So you have to pick up, because it's one of the very, very important preventable causes of mental retardation in the child. So you have to know that. So it poses a very big diagnostic challenge. Why? So you can see the TSH before birth. It's nice and very normal compared to that of the adults. But at birth, there is something happens to the TSH. There is a surge of TSH that is happening at the time of birth. That is due to a large amount of TRH that is coming from the hypothalamus that makes the pituitary synthesize a lot of TSH. The reason for that is at birth you will have a lot of stress. A lot of hormones will be released, including cortisol, because when the child is taken out through the vaginal canal and when they breathe for the first time, all these are significant stress for the child. So that, to cope up that, probably your TSH is surging. So during birth, at the time of birth, the TSH surges. After that, it doesn't surge. After that, it comes back and reaches the normal values like that of older children at around 4 to 6 weeks. By around 4 to 6 weeks. This is really important, because if you take the TSH values immediately after birth, in the newborn, the first day, it might reach as high as 40, 50 values. So which is definitely very, very abnormal in adults, isn't it? If you see a 40 or 50 in adults TSH, you think very severe hypothyroidism. But in a child, that 40, 50 immediately after birth may be a normal TSH, because the physiology is like that. Clear? So as a rule, what will be the normal TSH? This is a study graph that told you. Many studies have told that graph, what I have shown here in the second picture. What is an approximate TSH that should be used as a cutoff for diagnosing a congenital hypothyroidism? Remember, if you are seeing the TSH within 24 hours, usually many people advise against it, because within 24 hours, the TSH will be mad. It will be so high. We don't know the exact cutoff, but still a value of more than 60 can make you suspect a congenital hypothyroidism. In the 24 to 72 hours, a value of more than 30 may tell you it's a probable congenital hypothyroidism. After 72 hours, a value of more than 20 will tell you that this patient might probably having a congenital hypothyroidism. So the timing is very important. So when you collect the TSH, it's very important. Sample from the newborn. Usually after a week, after 1 week, just more than 10. At 1 week, the TSH of more than 10 itself should tell you there is some problem going on. If you take after 4 weeks, almost now it has come to the level of, like standard adults or older child. So just more than 6 itself should tell you there is some problem in the child. Clear? So which means it slowly declines and comes back to the normal range. This is the usual thing, even though a lot of graphs tell you a lot of different meanings, but this is the usual thing that you have to know. With subsequently, the screening, TSH will reduce, the cutoffs will reduce, the sensitivity will be at particular level, which you have to know definitely. Because if you don't know this, then you are prone for erroneous screening. So you have to know the fact that at birth, the TSH will be at its peak. Fine. Apart from this, is there any pitfalls? We have seen about the 5 pitfalls. These are not pitfalls, but you have to know this stuff. That's all. 6th one, yes. We know in non-thyroidal illness, it's very difficult to predict the TSH because in early and less severe non-thyroidal illness, that is CQ-thyroid syndrome, the TSH levels may be normal. But in late cases or more severe CQ-thyroid syndrome, the TSH levels may be grossly decreased. So which might confuse you towards either a central hypothyroidism or you might even think as a hyperthyroidism also. So you have to be a little careful here. 7th, lot of drugs can interfere with the TSH assays, can falsely lower the TSH. Dopamine can falsely lower the TSH. Octreotide, obviously it's a somatostatin analog known to decrease any hormone level. TSH also is not an exception. Then you can get reduced amount of TSH with a drug called bexarotene. This bexarotene is typically used in cutaneous T-cell lymphoma. It has a lot of side effects. It's a topical drug. It's like a vitamin A analog only. It's a topical drug where used for skin lesions of cutaneous T-cell lymphoma. A lot of problems are there like liver enzyme elevation and all. Not a topic of today. So we don't want to discuss bexarotene anymore. So these are very important drugs that can actually lower the TSH values. Clear? So a lot of drug related interference is also there. And finally, this is not related to your hypothyroidism, but there is one more point that can be considered as a pitfall of TSH, that in monitoring treatment for primary hyperthyroidism. Monitoring treatment of primary hyperthyroidism. So primary hypothyroidism, for diagnosis as well as monitoring, TSH is excellent. As far as primary hyperthyroidism is concerned, for diagnosing, TSH is very good again. But for monitoring treatment, TSH is not good, because I'll show you a graph when I'm talking about Graves' disease, where the TSH takes a long time to recover, even 3 to 6 months it takes to recover, whereas T4 recovers much faster if you start an anti-thyroid drug. So high T4, low TSH is the criteria. The T4, after you start the anti-thyroid drugs, the T4 comes to the normal level within a few days or weeks. But this TSH takes a long time to come to the normal level. So that's why TSH may not be a good thing to do and to rely upon in a patient who's having a primary hyperthyroidism and on anti-thyroid drugs. To monitor them, it's not a good tool. So these are some of the pitfalls or probably the problems that you have to know before thinking about a TSH, thyroid stimulating hormone. So fine. So now let us move on to the T3 and the T4. There are two ways how your laboratory is going to express this T3 and T4. One is the total T3 and T4 and second is the free T3 and T4. Total T3 and T4 I can also write as TT3 and TT4, and free T3 and T4 I can write as FT3 and FT4. Total T3 and T4 means it's a calculation of or addition of both bound hormones as well as free hormones. We know that. Clear? Since it's a calculation of both bound, that's a protein bound hormone, as well as a free hormone, this total T3 and T4 will be definitely influenced by the amount of protein binding by the hormone, and also be influenced by amount of binding proteins itself, or is there anything that displaces these molecules from the binding sites. So a lot of things will be the deciding factors for the levels of total T3 and T4. How they do that? They measure using an assay called a non-competitive immunometric technique. Non-competitive immunometric assay. Trust me, the total T3 and T4 measurements are much easier and simpler compared to the free T3 and T4 measurements, which are actually error prone and more cumbersome to measure, and a lot of calculations are there which you have to use. But let us stick on to the total T3 and T4 as of now and tell about the two concepts, because there are two things that you have to understand. One is called as a euthyroid hyperthyroxemia or euthyroid hypothyroxemia, and next you can write a euthyroid hyperthyroxemia. What do you mean by a euthyroid hypo and hyperthyroxemia? These are considered to be artifacts because of the changes in the TPG, where actually clinically the patient will be euthyroid, but the total T4 levels may be in the hypothyroid or hyperthyroid range. So let's see here. So this is the total T4, free T4 and the TSH values. In euthyroid hypothyroxemia, the total T4 levels will be low, but your free T4 and TSH levels will be normal. In euthyroid hyperthyroxemia, the total T4 levels will be high, but free T4 and TSH levels will be normal, which clearly tells you these changes that are happening in the total T4 is due to the changes in the TBG only, or there is something that is causing the problem in the binding proteins. That's why these changes are happening. So first discuss what is euthyroid hypothyroxemia. There are two reasons. One, there could be a low TBG itself or a TBG deficiency, which means the problem here is the low TBG, which means the bound hormones are more, 99.97% as far as T4 is concerned. So obviously when the TBG reduces, automatically your total T4 levels will drop. But the free T4 and TSH has nothing to do with that. So what are the conditions that reduce the total TBG so that your total T4 levels will drop? One is your congenital deficiency. Very rare, but it can happen. That is inherited as an X-linked recessive disorder. Second, certain drugs can reduce the TBG. In the context of drugs, we have discussed already in detail in the physiology section. I'll just recap it. The most important being the androgens. You know that estrogens will increase TBG, androgens will reduce TBG. And along with androgens comes the danazol. It's an anabolic steroid only, like an androgen. Then we have glucocorticoid treatment. Yes, they reduce TBG. Then niacin, L-asparaginase. These are some of the examples of drugs that reduce the TBG. Number 3, you can also get this low TBG in urinary leakage of TBG, like nephrotic syndrome, protein loss, in other endocrine disorders like acromegaly and Cushing's. Cushing's is easy to understand. It is like a glucocorticoid excess. So we know that. So similar to how glucocorticoid therapy reduces TBG. And there are also certain drugs that displace the thyroxine from the TBG binding sites. Drugs that displace T4 from the TBG. So if you displace T4 from the TBG, obviously your bound TBG will, bound thyroxine will reduce, so that the total thyroxine will reduce obviously. So what are the drugs that displace the thyroxine from the binding sites? Number 1, anticonvulsants like phenytoin and carbamazepine. Very important. Number 2, certain other drugs like high dose Lasix, high dose furosemide, but only in high doses. Third one, NSAIDs like mefenamic acid. It's also imperative to understand that these drugs displace T4 from the TBG only. Displace T4 from thyroid binding globulin. But there is one drug that displaces T4 from albumin, that is heparin. So this also can reduce the total T4 levels. How they displace T4 from albumin? In fact, they don't displace, they prevent the binding of T4 with albumin. Because heparin activates lipoprotein lipase, which in turn is going to increase the amounts of free fatty acid. This increased free fatty acid definitely will inhibit the thyroxine from binding to albumin. Fine. So this is the mechanism. So heparin can reduce the total T4 levels. So these are some of the conditions that affect the TBG. Because of that, you are resulting in a euthyroid hypothyroxemia. Let us now discuss on what do you mean by euthyroid hyperthyroxemia. So we know the fact that the total T4 will be increased, but free T4 and TSH will be normal. So what are the conditions that cause? Obviously, first thing I can write TBG excess. Increased TBG, obvious cause. And what are the cause of increased TBG? It could be congenital excess that's inherited as a X-linked dominant disorder, or similarly, there are certain drugs that can increase the TBG. The most important drugs that are very regularly asked in exams is estrogens, or giving hormone replacement therapy again due to estrogens, or receiving a tamoxifen, or some of the anti-cancer like drugs like 5-fluorouracil, other drugs like clofibrate, and opioids like methadone or heroin. So these are the conditions or the drugs that increase the TBG production, and they will increase the TBG as such. Next, you have to definitely know about the pregnancy. There's no doubt about that. And finally, hepatitis. Both acute and chronic hepatitis, they might increase the TBG levels in the blood. So these are the conditions that increase the TBG. At the same time, there are a lot of other conditions that produces this euthyroid hyperthyroxemia. Condition number 1 is, it could be an artifact. I discussed with you already that biotin, when you are taking in the diet in excess, more than 5 to 10 milligrams per day, it might cause falsely low TSH and falsely high thyroxine hormones. Artifact, I say artifact. Number 2, things that increase the TBG by unknown mechanism. We don't know how. First one, acute psychosis. Second one, high altitude. Third, amphetamines. We don't know the mechanism, how they increase the total T4, unknown mechanisms. And symptomatic hyponatremia. Finally, thyroid hormone resistance. You can write as THR, or you can write as RTH also, thyroid hormone resistance. So these are the conditions which produces euthyroid hyperthyroxemia, but we don't know the exact mechanism, how they do that. So you can divide the euthyroid hyperthyroxemia into different causes like this. So that's it. So we know that there are a lot of things that influence the total T4 levels. So that is the reason why we have to know the free T4 levels. So let us go and explore the free T4. So how they find out the free T4 and what are the ways to find out the free T4. So ways to find out free T4, there are 2 ways. One is called direct measurement of free hormone levels. Very cumbersome but very reliable. One important method is there in this, that's called equilibrium dialysis method. This is present only in very big tertiary centers only mostly. Usually small labs will not have this equilibrium dialysis, but this is supposed to be the most accurate. Most accurate for calculating the free T3 and free T4. Or you can have estimate. It's not direct, which means these estimates are indirect measurements. There are 2 ways how you can measure indirectly. One is obviously the immunoassays are there. Second one, you can calculate something called a free T4 index. Free T4 index. Plus, this is nothing but the total T4 that is corrected to TBG. The free T4 index is nothing but total T4 that is corrected to TBG. That's all. Plus, at the same time, you need to know the TBG levels also. Thyroid binding globulin levels as well. Fine. So these are the 2 principles of finding out the free T3 and T4 levels. In that, the most important method what they will be asking in exam is the free T4 index. Definitely important. What do you mean by the free T4 index? That is nothing but the total T4 that is corrected to TBG. So let us separately discuss on the free T4 index. So how you are going to calculate the free T4 index? Free T4 index will be equal to the actual total T4, and you have to correct this to the TBG. How you correct this with the TBG? You have to take a ratio called THBR. That's called the thyroid hormone binding ratio. This is otherwise referred to as a thyroid hormone binding index, or THBI. Both are correct. So now you know the total T4 already you have the assays for finding out the total T4. But what is this THBR? Thyroid hormone binding ratio or thyroid hormone binding index. What is this? So how will you find out this THBR? So the formula for THBR is T3 resin uptake ratio. that is nothing but T3 resin uptake in the patient, that is the test subject, divided by T3 resin uptake in the control, which means a normal T3 resin uptake. Normal T3 resin uptake must be somewhere around 25 to 35%. This is a normal. Average we take it as 30. 25 to 35% is normal, and average we take it as 30%. This is the average. But first of all, what do you mean by resin uptake? You have to know that, isn't it? If you don't know what do you mean by resin uptake, then how can you understand all these things? Let us explore what is resin uptake. So how they find out is, that's a very brilliant one. So where they give a radio label T3. This is a radio label T3, and how they label it with I-125. Common isotope used for this diagnostic practice and all in the laboratory, not to the patient. This is not given to the patient. Understand, this radio label T3 will be added to the patient's serum. So this radio label T3, initially they will bind to the TBG only because they have high affinity for TBG. So you know very well the TBG has a lot of this binding pockets. So it is very sure that some of these binding pockets will be occupied by already thyroxine and triiodothyronine. But there will be some binding pockets that will be free in the TBG measurement. I mean in the TBG that is present in the sample. So this radio labeled T3 will bind with the pockets that are free, and some will bind, and once the binding sites are saturated, some will be free. This T3 that is not bound, this radio label T3 that is not bound will be finally adsorbed into a resin. So this could be either a resin, or it could be a talc, or it could be even a type of a charcoal you can use for adsorbing this remaining T3 that is left behind without binding to the TBG. So indirectly, how can you calculate this is very simple. If you have a higher TBG, for example, if you have a high thyroid binding globulin, obviously the amount of binding with the TBG will increase because this radio label T3 has higher affinity for TBG only than to the resin. So they will first bind to the TBG only. So whatever is left only they are going to bind to the resin. So since there are high TBG and the high binding sites available for the radio label T3, they will prefer binding to TBG, and very little only will be available for the resin to be bound. So the resin uptake will actually reduce. So in a patient who is having a high TBG. So in a patient who is having a low TBG, reverse will happen because the binding sites will be very less. Available binding sites will be very less because the TBG is less. Lesser T3 only will bind, and that lesser T3 itself will saturate the TBG binding sites, and more T3 will be available for adsorption to the resin. So that resin uptake will increase. Very simple. Lower TBG, increase resin uptake. Higher TBG, lower resin uptake. Clear? So now let us tell all these things in a very simplified manner. Let us put a total T4. Let us put a resin uptake. T3 resin uptake, and write T3 RU. So what will happen in high TBG? In high TBG conditions, the total T4 levels will be high, whereas your T3 resin uptake will be reduced. No doubt about that. Similarly, in a condition where you have a low TBG, your total T4 levels will be low, but your T3 resin uptake will be high. But what will happen in hypothyroidism or hyperthyroidism? If you are dealing with the sure shot hypothyroidism, definite hypothyroidism, your total T4 must be reduced. Obviously, in hypothyroidism, obviously it will be reduced. The thyroid hormone synthesis itself is low, isn't it? But what will happen to the resin uptake? Please understand here, in a hypothyroid patient, the amount of T4 that will be bound to the TBG will be very less because the thyroid hormones are not enough to saturate the TBG molecules. So there will be lot of binding sites that will be free in the TBG that is normally circulating in the blood. So since there is lot of binding sites available, T3 will preferentially, this radio label T3 will preferentially bind to the TBG molecules, so that there will be very little T3 available for the resin. So you will have a low T3 resin uptake only. Similarly, if you have a hyperthyroid state, in hyperthyroid state, in a true hyperthyroidism, this is not a problem of TBG. It's a true hyperthyroidism where there is excess production of T4 in the body. So this excess T4 that is naturally produced in the body in hyperthyroid patient will go and occupy all the TBG binding sites and they will saturate the TBG. So when you give the resin, when you give the radiolabel T3, there will be no binding sites available so that they cannot bind to the TBG at all because it's already occupied by the T4 that is produced in excess in the body. So whatever T3, radiolabel T3 you give, they cannot be bound to the TBG so that they will be available for the resin. So the resin uptake will increase and the total T4 also will be increased because it's a hyperthyroid state, real hyperthyroid state. So this is very, very important for exams. So what are the things you will see in a low TBG state, high TBG state, and hypothyroid state and a hyperthyroid state? So let us calculate by an example. Suppose if you are having a total T4 value of 12 and my T3 resin uptake value is probably around 20%. Normally it is 25 to 35, average is 30, but in this it's only 20% uptake is happening. So how can I calculate the free T4 index? So now I calculate the free T4 index. I already told you that free T4 index is nothing but your T4 that is corrected to the TBG. In a way, clear? So here the total T4 is 12, that is multiplied by the T3 resin uptake in the test subject, that is the patient. Here it is 20% divided by T3 resin uptake in the control, which is normal T3 resin uptake, that we take average as 30%, that is 30 here. So 12 into 2 by 3, you will get approximately 8. So which means this is the corrected total thyroxine, which means corrected to the TBG. The total thyroxine is 12. Here the TBG is very high. That is the reason why your resin uptake is low. So it is the corrected T4, which means this is what we refer to as a free T4 index. Please understand the fact that this is not the free T4, it is the free T4 index, not the free T4 value. To know the real free T4, there is one more step that is involved where you have to calculate based on the actual TBG levels that you see in the blood. You have to calculate the TBG level, and after calculating the TBG level, you have to use the free T4 index. There is another calculation which will finally give you the actual free T4 levels. So once again I am telling you, free T4 index is nothing but the total T4 that is corrected to the TBG. That's the idea. Clear? So this is what the free T4 index is. Definite question exam, so you have to know about this 4 important points. They will surely ask about this. Clear? So here we can write the TSH also at the same time. Remember, if it's a true increase in the TBG only, the TSH levels will be normal only. But if it's a real hypothyroid state, TSH will be high. If it's a real hyperthyroid state, TSH will be low. If we are talking about a primary disorder, where primary is the most common, isn't it? Secondary is not common. So we are not talking about a secondary disorder here. So clear? I purposefully didn't tell about one important disease, that is familial dysalbuminemic hyperthyroxemia. So this is a condition that is going to be classified under euthyroid hyperthyroxemia only. So which means what you expect, so your total T4 will be high, your free T4, biological free T4, and TSH must be normal. That's what you expect. Yes, that's what happens here as well. So what is the problem here? Here, you have a mutated albumin that is actually having more affinity for T4 but not for T3, which means normally TBG only should have high affinity, and TBG is the principal carrier protein for thyroxine. But here albumin also becomes the principal carrier protein for thyroxine, so that the net binding capacity of the plasma to T4 will expand. That's what we're going to see here. Let us see. So let us assume this is the TBG and this is the albumin that is mutated. Normally your TBG only should be carrying thyroxine, but here albumin also starts carrying a lot of thyroxine, which means when you take a total T4, which is a measurement of bound T4 plus free T4, here the free T4 is normal, but the bound T4 will definitely expand, resulting in increased total T4 as well, because now the albumin is also increasing the binding capacity. Clear? Because this is the mutated albumin. But very worth noting point is it will not bind to T3, whereas T3 will bind to still TBG, there is no problem, but albumin, this mutated albumin will not bind to TBG. It's having usual affinity. They don't have any increased affinity for T3. So this is the key here, which means your total T3 may be normal completely. This is first peculiarity. Total T3 can be normal, only total T4 may be raised. But second peculiarity is the fact that the resin uptake also will be normal. It's very, difficult to understand. So why the resin uptake is normal? Because in resin uptake test, you are using the T3. So the T3 can normally bind to TBG like a normal person, but still it will not be able to bind to the albumin because this albumin is not going to have a good affinity for T3. So the entire overall resin uptake will be normal. Let us see how in a diagrammatic way. You're having a TBG and you're having an albumin. Same thing I'm telling. It's going to bind to T4. The albumin is also going to bind to T4, but when you are giving a radio-labeled T3, this is a radio-labeled T3 with I125. So this actually can bind with the TBG, which means like normal people, but you know that this albumin cannot bind with T3. So whatever that is remaining will be adsorbed by the resin. Whatever that is remaining will be adsorbed by the resin. So here, since the TBG is normal, there is no problem. And the albumin is also normal, but just is having high affinity for T4. But it cannot bind with T3. So whatever T3 that binds with TBG, remaining T3, radiable T3 will be adsorbed in the resin, resulting in a normal resin uptake only. There is no problem. So what will happen to the FT4 index? Here the entire FT4 index will be corrupted. FT4 index is nothing but the total T4 that is corrected to the TBG by measuring a ratio called thyroid hormone binding ratio. Here thyroid hormone binding ratio will be normal because thyroid hormone binding ratio is based on resin uptake. T3 resin uptake, here it's normal. So it will be normal. So here the total T4 is increased, resulting in increased free T4 index. So when you calculate the actual free T3 using the free T4 index, it will be raised. So it might look like it's an artifact. It's not a true thing. In reality, you are having a normal free T4 in the body only. That is the reason you are having a normal TSH. But because of this artifact produced by this resin, normal resin uptake, your free T4 levels may appear as if they are increased. Clear? So how to avoid this bias? No, in India it's very uncommon. So don't need to worry about in Indian population, especially in Mediterranean, Ashkenazi Jews. Those population may have this kind of mutant albumin. So in those population you have to do something different. Best thing is to directly measure the free T4 using direct measurements. Don't use indirect measurements like this. That's why it's giving an artifact. Direct measurements like equilibrium dialysis may help you. You can know what is the exact free value. And second thing, instead of using this T3 for T3 resin uptake, you can use T4 for resin uptake, radio-labeled T4. If you use radio-labeled T4 for resin uptake, now what's going to happen? Now this albumin is going to take up a lot of T4 because it's having high affinity for T4, resulting in more binding of the radio-labeled T4 to the albumin and TBG, resulting in reduced binding to the resin. So you know that now the resin uptake is reduced, which will result in lower free T4 index, so that the overall corrected free T4 will be reduced and it will be normal only. So this is how you prevent the bias, but not important for us right now. So just for your knowledge, I told you, let us go back and see what happens in reality. So this is the normal resin uptake. You can see what happens. See the box size, it's a normal resin uptake. So here you are giving a radio-labeled T3. This radio-labeled T3 is binding with the usual binding sites in the TBG. Some are binding and some are binding to the resin. This is considered to be normal. But what happens whenever the TBG values are low, when you have a reduced thyroid binding globulin? You can see the amount of binding sites available is very less, which means this radio-labeled T3 cannot bind with TBG here. Instead, a lot of radio-labeled T3 will be free, that will be binding to the resin, resulting in expanded resin uptake. Here in low TBG state, your resin uptake will be high. You can compare with the size of the box here. Whenever you have a very high TBG, what's going to happen? Lot of binding sites will be free in the TBG itself, which means so much of radio-labeled T3 will be bound to the TBG itself, leaving very little to be bound to the resin. So the resin uptake will be reduced. Compare with this, here the resin uptake box size is high, here box size is very small, resin uptake is very little. This is a familial dysalbuminemic hyperthyroxanemia, where here the radio-labeled T3 is normally binding to the TBG molecules, which is normal. But This mutated albumin molecules bind only to T4. They cannot take up the radiolabeled T3 or any form of T3. So which results in normal binding with the TBG, but remaining will go to the resin, which means resin uptake overall will look normal only. Because this albumin will take up only T4, expanding the total T4 only, but the T3 resin uptake will be normal because they don't bind to the T3. So overall resin uptake will be normal. These are the 4 images that you have to know. So to understand things better, that's it. So we have completed the total T3 and T4 biases also, and we are moving on to the next and final investigation, that is anti-thyroid peroxidase antibody. Anti-TPO antibody. Anti-thyroid peroxidase antibody is also referred to as anti-microsomal antibody. Currently we use the term anti-TPO only. Anti-thyroglobulin antibodies, on the other hand, we don't use it at all nowadays. To be honest, only anti-TPO has some clinical utility at least, but definitely do not do routinely, not routinely done. That's very important. Don't do routinely for all patients of hypothyroidism. Only selected patients we do. But what it can tell if it's positive, it's threefold importance is there of anti-TPO. The first importance is if anti-TPO is positive, it tells you that the patient is suffering from some form of autoimmune thyroid disease. That's it. It will not tell you exactly what is the type of thyroid disease, but it will tell you there is some form of autoimmune thyroid disease that is running in the patient, which means it is non-specific for a particular type of autoimmune thyroid disease. Probably it could be seen in Graves' disease, it could be seen in Hashimoto, doesn't matter. It's non-specific. But extremely high titers of this anti-TPO antibodies indicates that the patient is probably suffering from Hashimoto's disease. Probably, but not confirmed. Then, second importance, presence of anti-TPO indicates there is an increased risk of conversion of a patient from a subclinical hypothyroidism to overt hypothyroidism. First, let me tell you what will be the picture of a subclinical hypothyroidism. Subclinical hypothyroidism, usually they will have a normal T3 and a T4, but they'll have a high TSH. And the prevalence of subclinical hypothyroidism is actually quite common compared to overt hypothyroidism. It is 3 to 15% in the community. In different populations, it will differ. Similarly, in overt hypothyroidism, your T3, T4 will be low for sure, but whereas the TSH will be high again. So this is overt hypothyroidism. This is a gross hypothyroidism. The prevalence is approximately 0.1 to 2%, depending on the population you are dealing with. Normally, there is some chance of conversion of this subclinical hypothyroidism to overt hypothyroidism, for sure. Some risk is always there. Whenever you get the subclinical hypothyroidism, the normal risk of conversion to overt hypothyroidism in a few months or years is approximately 2.6% per year. So this is the risk, usual risk. But suppose your TSH values are not very much elevated, which means normal TSH is somewhere around 5. That's the upper limit of normal. But the TSH is elevated, but if the TSH is less than 7, just borderline elevation, these kind of patients do very well, which means at 2 years, almost 50% will normalize the thyroid function, which means the TSH will look normal after 2 years. In 50%, almost 46% is the exact number, but we can keep it an approximate around 50%. Almost half of the patients will normalize the TSH within 2 years. So especially if the TSH is less than 7, which means TSH less than 7 in a patient with subclinical hypothyroidism is good, which means most of them will normalize, almost half. At the same time, the usual risk, whatever may be the TSH, irrespective of the value of TSH, it could be 6, 7, 8, the risk of developing a overt hypothyroidism is 2.6% per year. But this risk is extremely high, increased risk, if the patient is anti-TPO positive. The risk can be up to 8 to 10% per year if the patient is anti-TPO positive. If the patient is anti-TPO positive, the risk of conversion from a subclinical hypothyroidism to overt hypothyroidism is very, very high. So that's what I'm going to tell. So it can predict development of overt hypothyroidism, predict development of overt hypothyroidism in 3 populations. Population number 1, those who have a goiter. Patient has a goiter, presence of anti-TPO predicts very high risk of development of overt hypothyroidism. Second, if the patient is having a subclinical hypothyroidism. That's what we have been talking about all this while. Patients having a subclinical hypothyroidism, this predicts a high risk of development of overt hypothyroidism in those patients. Irrespective of the TSH levels, it doesn't matter. Number 3, patients who are taking certain drugs like amiodarone and lithium. Patients who are taking amiodarone and lithium, this presence of this anti-TPO antibody at the time of giving amiodarone and lithium predicts that these patients are at high risk of developing hypothyroidism induced by those drugs, which means it becomes like an additive effect. Amiodarone and anti-TPO both acts as additive effects so that there is increased risk of developing hypothyroidism in the patient. In fact, it's overt hypothyroidism. So these are the very important points that you have to know. Clear? In general, leave the anti-TPO. What are the other predictors that will tell you there is an increased risk of conversion to overt hypothyroidism, progression to overt hypothyroidism? Female sex. As such, females with subclinical hypothyroidism generally have a higher risk compared to that of males for development of overt hypothyroidism. At the same time, if you have a low normal range of T4, if you have a T4 that is in the low normal range, in the sense like T4 is not a very good T4. T4 is also in the borderline. It's not completely out of the range. It's not very low, but it's in the normal range, but in the low normal range. These two factors also predict that these patients may develop overt hypothyroidism eventually. Clear? So this is a very important point. Again, all these are trial-based data, so very paka clinical material, so you have to know that. Then, what are the third thing that anti-TPO positivity predicts? It is very important in obstetrics because there is one study which came. I'll tell you the study first. Patients who are going for assisted reproductive techniques like IVF or ICSI. IVF is in vitro fertilization, ICSI is intracytoplasmic sperm injection. These patients who are having anti-TPO positivity and those who have TSH value of more than 2.5. So there are 3 trials which have clearly proven in these patients there is increased risk of adverse pregnancy outcomes, which means those who are conceived with assisted reproductive technique and those who are anti-TPO positive and those who have TSH of more than 2.5. They have adverse pregnancy outcomes. In general, in particular, they have told about increased risk of pregnancy loss in these patients. So this is the 3 trials that consistently proved this data that is correct. Later on, obstetricians extrapolated not only to the assisted reproductive techniques, they have extrapolated this data to the normal conceived patients also, normally conceived patients without any assisted reproductive techniques. So right now, the idea is very simple. In pregnancy, if your anti-TPO is positive and if TSH is more than 2.5, you have increased risk of adverse outcomes, especially pregnancy loss. Very important point. That is why whenever you are anti-TPO positive, whenever a pregnant mother is anti-TPO positive, especially if they are coming with infertility, then only you do this anti-TPO. Anti-TPO, especially recurrent stillbirths, recurrent abortions, bad obstetric history, you do an anti-TPO. And see anti-TPO is positive. If TSH is more than 2.5, you have to definitely treat with levothyroxine. This is the only area where you keep the upper limit of normal threshold of TSH to be at 2.5 at such a low level. I told you in usual pregnancy it is 4, that too only in the first trimester. And in other people, non-pregnant individuals, it is somewhere around normal range, that is 4.5 or 5 or 5.5 depending on the laboratory range. But this is the only area where you keep the upper limit of normal of TSH as 2.5 at such a low threshold. Only if a pregnant mother is having anti-TPO positive, especially if you are going for assisted reproductive technique or if they are having a bad obstetric history. Definitely have to be very careful. Clear? So you have to give levothyroxine even if the TSH is 2.6 or 2.7 to bring the TSH to less than 2.5. So this is a very, very important point, crucial point. Remember, so in overall, the exam point will be anti-TPO is associated with adverse pregnancy outcomes, especially increased risk of pregnancy loss. Box that point, very, very important. Might be asked in institute exams. It's an institute material. So what you're trying to do here? So what you're trying to do is to keep the TSH to less than 2.5. Is there any benefit to keep the TSH to less than 2.5 in a patient who is anti-TPO negative? Absolutely no. That's also a very important point. If anti-TPO is negative, no point. There is no need to keep the TSH2 less than 2.5. Clear? So this increased risk of adverse outcomes and increased risk of pregnancy loss is not seen up to 5 to 10. Different trials tell different data, but only if the TSH is more than 5 to 10, your increased risk of pregnancy loss is there if the patient is having anti-TPO negative, which means it's like same like other people only. There is nothing significant here happening. So anti-TPO is positive, then only it's 2.5. Negative, it's not 2.5. You can keep a very high cutoff of 5 to 10 also. And again, that is a very controversial gray area. No need to touch that. Okay. So what are the 3 important arms of this anti-TPO use? Suggests there is some autoimmune thyroid disease. Second, it predicts the risk of development of overt hypothyroidism in patients who are having goiter, subclinical hypothyroidism, or patients who are receiving amiodarone lithium. Third, patients who are having anti-TPO positive and TSH more than 2.5, especially if they are having assisted reproductive techniques, there is a high risk of pregnancy loss. That's all. 3 points gold standard for anti-TPO, that's enough. Clear? So I think with this, we are completing the part 1 and the session 1, as I told you, for the hypothyroidism. In the second session, we'll be discussing on the core aspects of hypothyroidism and how you classify congenital hypothyroidism, adult hypothyroidism, and what are the treatment aspects and what are the clinical features of congenital as well as adult hypothyroidism.